Hi everybody, good morning. And I'm back. Parang hindi ako nag-live kayo ng umaga at saka kayo ng hapon ano. Anyway, it's me again. It's me, John, and I'm just glad to be back again. I just had my supper and oh my god, I'm so full. I ate a lot. Well, sa mga hindi nakakaalam, I don't know how to cook, so I just ordered some food, have it DoorDashed. I had some Korean food. Sarap, grabe. Okay, anyway, before we start, shout out to Joe Orange. Hi there. Where are you from? And it's 8:16 in the evening, Central Time. Good morning po sa Pilipinas. I don't know what time is it in the Philippines. Ano oras na ba sa Pilipinas ngayon? But definitely it's morning time. We'll see. Hey Siri, what time is it in the Philippines? It's 9:16. No, it's 9:16. No, not New York. What time is it in the Philippines? Hindi ako naintindihan ni Siri. But anyway, I know it's morning in the Philippines and welcome back. This is part two. This is part two of electrocardiography. And I hope that before you will continue with this clip, with this stream, you watch part one of electrocardiography, wherein I had an introduction about the basic physiology of conduction system in the heart. Okay, it's very important for you to watch that clip before you proceed this one. Don't worry, I will not delete this file. Okay, you will have this for a couple of days, probably. So this is a simultaneous streaming sa, what do you call this? US Review Center, my Facebook page, and of course, the Chronicle of Medical Surgical Nursing. So if you have any questions, please feel free to drop a message. If you want to ask something, I can read your comments. I can read your whatever is on your screen. I will see that. Hello, Joe Orange. Hi. Hello, Jay Olirum. And sa mga friends po natin sa Pilipinas, relative friends, countrymen, good morning! So, you know what? Kayo ng umaga, hindi pala kayo ng hapon pala. I was having my part 1 sa electrocardiography and parang maaga kami natapos. And I asked some students to drop a message if they want me to discuss some concept. And we talk about blood, the RH incompatibility. We talk about autonomic dysreflection, and napag-usapan din namin yung, ano ba yun? Yeah, yung dalawa. And I keep on talking. Salita ako ng salita. Unfortunately, hindi ko pala nangyari sa buko sa likod. Hey, what is this? Hold on. Salita ako ng salita, tapos nakalimutan kong i-share yung screen ng monitor ko. So hindi nila nababasa yung naisusulat ko sa whiteboard. So I told them that I will repeat that discussion here before I will proceed with the part 2 of your electrocardiography. So I hope that's okay with you guys. Anyway, it's a learning process. Please don't mind my loop. Okay, what's the most important here is the concept and the thing that you can learn along the way. Hi, Glenidine de Guzman. Hello. Bakit pa mag-hello kayo? Ang daming letter O. No? Parang hello. Okay. Hello, Glenidine. Tagasan po kayo. And hello to Imelda Hover or Jover. Hi, good morning, Imelda. Abisha Santa Maria, hello from New Jersey. Hi there. How's everybody there in New Jersey? Nakapunta ako ng New Jersey parang 4 na beses na sa I forget the place. Lakewood. And then I went to your mall. Ganda ng mall doon. What's good about New Jersey is that it's near New York. So kaya nga pag pumupunta ako ng New York, I don't stay sa mga hotels sa New York. I stay sa New Jersey. Yeah, it's cold. Same here in Minneapolis. It's cold. And we had a terrible winter storm a few weeks ago. So you have to stay warm, stay safe. Santa Maria, Abish, are you planning to take the NCLEX anytime soon? or you passed the NCLEX, andito ka lang para makinig. What's your plan? Tell me. (32 degrees). Same din, mga 30 plus din dito. Tingnan natin. Saglit lang. Let's see. Oh, same, 32 degrees. 32 degrees, but we don't have snow. Not until Thursday. Yes, I will take this March. Okay. Glenadine is from Caloocan City. So excited for today's discussion. Oh, that's great. So this coming March. So sana ipasa mo yon before mag-start yung new generation NCLEX RN. So, hey Glenadine, were you around sa discussion ko kayo ng umaga? Saglit lang. Hold on. May nag-message sa akin. Heads up. What is this? Heads up, January 18, Wednesday, concept medical surgical nursing. What is this? What about this? A certain Facebook user just sent me a message, and then she gave me a list of, this is not from her, it's a forwarded message actually. So I want to ask, okay. Oh, okay. Mga students, sir, needed help about these topics. So, may nagpadala sa akin ng message. Itong haba-haba. O, tingnan niyo. They want me to discuss a lot of stuff. Peptic ulcer disease, cholecystitis, liver cirrhosis, hepatitis A, B, C, D, E, pancreatitis, ulcerative colitis, Crohn's disease, appendicitis, diverticulitis, intestinal obstruction, diabetes mellitus, hypoparathyroidism, hypothyroidism, diabetes insipidus, pituitarism, Cushing, and Addison's disease. Okay. Ang dami nito Oh God. It's okay. So we'll see. If I have enough time, I will discuss these concepts. And we have Zane Dwell, Sir John Batch 2006 ako. I love your classes during the review then. Oh, thanks a lot. It's nice to see you here. Trying to reconnect with all of my students, previous students. Yeah. So for those who don't know me, my name is John Hilrica Ford. I'm doing review or coaching for the qualifying examination for nurses. I've been doing this for 21 years. I started doing this way back 2002. And then when I was still in the Philippines before coming here in the US, I got tied up with the different review centers. Yeah, so I've been teaching medical surgical nursing. And then prior to that, I used to be a clinical instructor. So technically, my umbilical cord is attached to teaching. So still in the academe. So way back during the clinical instructor days sa isang school. So I taught anatomy, physiology, pathophysiology, pharmacology. Ano ba tinuturo ko dati? Yun. Tsaka fundamentals of nursing. And then sa review, I started with maternity nursing for few months. But after that, sabi ko, I don't like teaching maternity nursing. Mas maganda siguro ang magturo ng MCN babae. So nag-focus ako sa med-surg. That's my first love. And then from then, hindi na ako naalis sa med-surg. So that's it. So I'm just glad that you're here, 2016. You know what, Zane? You made me feel old. My God. So John took it at 2006. Oh my God. How long was that? I feel so old now. Pero sabi nga nila, age is just a number. We'll see. Ilang taon na ako? I'm very young. I am a high school principal. I am actually 42 years old. Ay, hindi pala 22 years old. Anyway, so let's start. Let's try to turn off the background bed music and then let's talk about uh, medical surgical nursing. Okay? And please remind me if hindi nababasa yung or hindi ko na screen na share yung screen or monitor ko. Okay? And feel free to interrupt me, drop a question if you want to ask something. Please, okay? Please. If I don't know the answer, I'll be brutally frank with you guys. But if I know something, I'm very much happy to share what I learned and what I know. Okay. So, sabi ko nga before we will talk about before we will continue with the before we will continue with electrocardiography part 2, I need to discuss something na hindi ko na share yung screen ko kanina before I ended the part 1 of electrocardiography. And that was actually 30 minutes before the end the end of part 1. So I need to discuss it again. Oh my God. Okay, so allow me to share my screen. Share screen. Okay. Whiteboard. Ito yung diniscuss ko kanina na hindi ko na share yung screen. Would you believe that? So uulitin ko na naman siya. Okay. So may estudyante kayo ng hapon and requested if I can discuss ROGAM, blood, and I did. Unfortunately, I failed to share my screen, so I need to do it again. So let's talk about blood. Okay, let's talk about blood. Bakit pula yan? I want it color black. Okay, so let's talk about blood. So blood is actually the only fluid connective tissue, and blood constitutes 8% of the total body weight. In short, if you weigh 80 kilograms, 8% of that is from the blood. Okay. And guess what? Your blood serves 3 basic functions. Blood is important for transportation. It will transport nutrients, gases, electrolytes, water. Blood will even transport cancer cells. Okay. Blood will even transport microorganisms. Okay. That's for transportation. The second function of your blood is protection. Protection against what? Protection against bleeding, protection against infection, because blood has platelet, blood has clotting factors. So those will protect you against blood loss. And of course, protection against infection, because blood has WBCs. There are soldiers in the body, in the blood, that will fight off microorganisms or fight off infections. Not only that, we also have antibodies or immunoglobulins that will protect you as well, which is part of your immunology. That's your immunology concept. That's the second function of your blood. The third and the last function of your blood is regulation of temperature. Okay, so these are the 3 functions of your blood. Okay, transportation, protection, and regulation of temperature. Now, blood has 2 basic components. What are the 2 basic components of your blood? You have your plasma, and we have the form elements. Okay, now if present po kayo when you were around when I talk about fluid compartments, you would appreciate the plasma here. I said that plasma is 55% of the total blood volume. Okay, and form elements will be 45% of the total blood volume, and plasma is the liquid part of your blood. Now, when I say form elements, okay, these are the following. We have the RBC, we have your WBC, and we have the platelet. RBCs, these are what we call erythrocytes. WBCs, these are your leukocytes. Platelets, these are your thrombocytes, okay? And among the form elements, it is the RBC that is most abundant, okay? Most abundant among the form elements. Now, what else? Blood is actually formed in the bone marrow, in the red bone marrow, and inside the bone marrow, there is a cell. Okay, you call this cell as your pluripotent stem cell. This is different when you say omnipotent and impotent. Okay. Now, when you say pluripotent means that from a single cell, it will divide into different types of cells. Okay. That's your pluripotent stem cell that's inside the bone marrow. Now, this pluripotent stem cell will divide into two. Okay. Divide into two cells. First is what we call the myeloid cell, and the other one is your lymphoid cell or the lymphoid stem cell. Your myeloid cells will transform into three cells: the RBC, okay, the WBC, and then your platelet. Remember, these are your form elements. Okay, so that these RBC, WBC, and platelet, they originate from the myeloid. That is why if a patient has proliferation in the myeloid stem cell, what will happen? The RBC count, the WBC count, and the platelet count will increase. And that is a type of a disorder. Now, what do you call that disorder if all these form elements, all these cells are elevated? You call that condition as your polycythemia vera. Okay, but if these cells are low, okay, decrease RBC, decrease WBC, decrease platelet, we call that condition as your pancytopenia. Okay, now what about your lymphoid? Lymphoid will divide into two. Okay, we have that. Okay, we have this B lymphocytes or the B cell, and T lymphocytes or the T cells. Okay, the B lymphocytes will transform into plasma cells. And these plasma cells are cells responsible in what we call immunoglobulins. Another name for immunoglobulins, you call that as your antibodies. And I hope you're still familiar with your gamed, or some would say it's gammed. So immunoglobulin G, immunoglobulin A, immunoglobulin M, immunoglobulin E, and immunoglobulin D. So I discussed this in detail pag nasa actual review tayo. This falls under your immunology concept. Anyway, the B lymphocytes or the B cells are cells, actually is a cell precursor or responsible for what we called humoral response. Other book, it's not humoral response. Other book, they call it as humoral mediated response. Okay. And another cell produced, okay, from your lymphoid is your T cell or the T lymphocytes. Now, some book will say that the T lymphocytes produced by the lymphoid or derived from the lymphoid are useless cells, not until the T lymphocytes will go to your thymus. Oh, there's another structure, thymus. Now, where is your thymus situated? Your thymus is actually located or situated at the back of the sternum fronting the heart. Okay, back of the sternum fronting the heart. When you were still young, the thymus is huge. Malaki yung thymus. But when you grow old, as you grow old, the thymus will shrink, the thymus will decrease its size. Now, what's so special about this thymus is that when the T lymphocytes enters the thymus, the T lymphocytes will undergo proliferation and differentiation. Okay, so as a result, if there's differentiation and proliferation of T lymphocytes in the thymus, what will happen? It will transform the T lymphocytes to a more specific cell. So it will turn into what we call helper T cell. It will turn into killer cell, magiging memory cell, okay, and magiging suppressor T cell. See, magiging useful siya, specific. And by the way, another name for helper T cell, you also call this as your CD4 cell. If you're familiar, we use CD4 to evaluate a patient with HIV infections, right? Because if the CD4 count is less than 200, if the CD4 count is too low and the patient is accompanied with some opportunistic infections, you now call that as an AIDS, okay, or acquired immune deficiency syndrome. So basically, when you say AIDS, AIDS is a full-blown HIV infection. Okay? So anyway, so if B lymphocyte is a cell precursor for humoral response, what about your T lymphocytes? Your T lymphocytes are the scale or is a cell responsible for cell mediated, okay, or cellular mediated. cell-mediated or cellular-mediated response. So, alam na natin. Anyway, this is under the concept of immunology. And sometimes may kasama pa yan na concept, ano nga yung sinabi ko kanina? Um, active passive immunity, if you can still recall that. And it is further subdivided into two. We have your natural and the artificial passive and active immunity. Okay, so this is how blood is being formed. Okay, so if you notice from a single cell, na pluripotent, this cell from a pluripotent cell, stem cell, it divided into different types of cells. So we call that cell as pluripotent. Remember, pluripotent means from a single cell, it will divide into different types of cells. Okay, and another thing to remember about blood will be the blood types. The blood types. Let me see if you have any questions. Hold on. Okay, let me see. Where is that? This is a continuation. I wanna see if you have any questions. Oh, my friend Roberto Elias is watching me. Hi, Roberto. Young Kapasar RJ de la Victoria. Young. I hope so. Anyway, so let's proceed. Anyway, can you see me, guys? I cannot see myself here. Okay. Learning from Rosario Cavite. Anyway, guys, can you see me? It's kind of weird. See? I cannot see myself. Hold on. Hi, Elsie. Hello, Mom Elsie. Hello, Anne Repato. How come I cannot see myself? Can you see me, guys? Can you see me and can you hear me? Please. Yes, okay. Just making sure. Okay, so let's proceed. Okay, blood types. So we know the different blood types, right? So we have here blood type A, blood type B. We also have type O and type AB, correct? So let's identify presence of antigen and presence of antibodies. So let's check. If your blood type is type A, what antigen do you have in your blood? Okay? So if your blood type is A, your antigen in the blood is A, and then your antibody is B. If your blood type is B, your antigen in the blood is B, and then your antibody is A. If your blood type is O, it means to say you don't have antigen, none. But you have antibody A and antibody B. If your blood type is AB, you have antigen A and antigen B in the blood, but you don't have antibodies. Okay? So take note, a blood type O does not contain any antigen. Therefore, if there's no antigen in type O, no antigen means that it cannot cause any immune response or immune reaction. That is why type O is the safest blood because it does not contain any antigen. So no antigen would mean that there is no immune reaction. Okay, next. Another thing to remember about blood type will be, what do you call this? The RH, or rhesus. So a blood can be RH positive or a blood can be RH negative. So what is the implication? If the blood is RH positive, it means to say the blood has antigen with RH antigen. Okay? If the blood is RH negative, implication is that blood does not contain RH antigen. And by the way, an RH antigen can be found in the RBC. Okay? So again, an RH positive blood means with RH antigen. RH negative blood means without RH antigen. Okay? So it could be positive or negative. So apart from your RH presence, RH antigen presence, you need also to familiarize the blood types. Now, I want to talk about RH incompatibility here. Okay? So RH incompatibility is common to patient with a blood type of RH negative. So I hope that is clear. So you will have RH incompatibility issue if your blood type is if your blood is RH negative. But if you are RH positive individual, your likelihood to have RH incompatibility is very low. Okay, so I will talk about RH incompatibility into two concepts, the maternity nursing concept and the medical surgical nursing concept. So here. So this is your maternal child nursing. And this is your medical surgical nursing concept. Okay? So this is a pregnant mother, okay? And please bear with my drawing. So this is a mom said to be an RH negative mom. Okay? It means to say that the pregnant is a person wherein the blood does not contain any RH antigen. And this is the developing fetus inside. Okay? And this is the placenta. And that's the only link between uh, baby and the maternal area, that's your placenta, correct? Now, it just so happened that the baby inside is Rh positive. So again, mom is Rh negative. It means to say does not contain Rh antigen. The baby inside the uterus is Rh positive. It contains Rh antigen. Remember, what did I tell you? If it contains antigen, then it can cause immune response or immune reaction. Now, let's say this pregnant person had an accident, bumps his tummy, or had an accident that causes fetal leakage. Okay, remember that the only link between the fetus and the baby and the mother is the placenta. If accident happened and unfortunately the fetal blood leaked, leaks into maternal circulation, even 1 to 2 drops of blood only. Okay, so if the fetal blood joins the maternal circulation of even 1 to 2 drops only, that 1 to 2 drops of blood contains Rh antigen. Since it contains Rh antigen, what will happen now is that it activates immune system. Okay, it activates the immune system of this person. And once immune system is activated or immune response is activated or facilitated, there will be production of what we call antibodies. Okay, antibodies. Now, what is the purpose of this antibody? This antibody will destroy the Rh antigen, and it will go directly to the RBC of the person because I said Rh antigen can be found in the RBC. Okay, and what will happen now? It will destroy or kill the baby. Okay, or if not, let's say during delivery, remember you're in the delivery room. Okay, there is a risk of fetal blood leakage. It causes immune system response. There's production of antibodies. Unfortunately, this fetus is so lucky that when antibodies are actually formed, nakalabas na siya, it was expelled out. The baby was delivered. So since the baby is out from the uterus, this antibody is so late. So late. So where's the antigen? No more, because the baby was already delivered. In short, in maternity nursing, the first pregnancy is safe. The first pregnancy is not affected. Okay, the problem with your Rh negative mother is not the first pregnancy, but the succeeding pregnancies. succeeding pregnancies provided that the RH is positive. Okay? So what will happen? Let's say a year after this mom got pregnant again. It got pregnant and then it got pregnant and the baby inside the uterus is RH positive. Remember the antibodies that were formed from the previous pregnancy? This antibody formed from the previous pregnancy is again reactivated, and then once reactivated, it goes it goes directly here and destroys the developing fetus inside. So it will kill the baby and you will have miscarriage. Mahuhulugan yung mama. Okay? So lahat na mabubuntis siya succeeding or after the first pregnancy, succeeding pregnancies na RH positive, mahuhulugan siya. Can you follow? So anong implication? Your nursing responsibility here is that if a mom is RH positive, please be reminded that within 72 hours, okay, within 72 hours after delivery, you have to give ROGAM. So what is the purpose of ROGAM? The purpose of the ROGAM is to inhibit or prevent antibodies formation. So the purpose again of ROGAM is to prevent antibodies formation. That is under your maternity nursing concept. So again, in your RH incompatibility, this occurs if mom is RH negative. Because I said if you are RH positive, there is less likelihood to have RH incompatibility. Okay? So that's your maternity nursing. What about for medical surgical nursing? Let's say this is our patient and the patient has what we call blood loss. And unfortunately, that patient requires massive blood transfusion. A patient is RH negative and we need to do blood transfusion. When you transfuse blood, what type of blood will you give? An RH negative? Sorry, or an RH positive blood? Remember, our patient is RH negative. Ideally, you have to give an RH negative blood. That's the ideal. But can you give RH positive blood to a patient who is RH negative? Okay, baka mabash na naman tayo nito. You have to listen carefully. You can give an RH positive blood to RH negative person provided that is his first time to receive blood which is RH positive. After giving this blood, succeeding transfusions throughout his life, for life, okay? Lagyan natin na for life. Ayan. Succeeding transfusions throughout his life must be RH negative. Why? When you give RH positive blood to a patient who is RH negative, okay, when that blood enters the circulation, again, same thing happens. It will stimulate the immune system of this person, okay, to produce immunoglobulins or antibodies. That is why succeeding transfusions throughout his life must be RH negative. The moment you give RH positive blood the second time around, okay, these antibodies formed from the first time he received the blood, which is RH positive, is activated and will destroy its own body. Okay? Will destroy its own RBC and the patient will die. Okay? So again, an RH negative an RH negative person, ideally, he will receive RH negative blood too. But can we give RH positive blood during emergency cases if we cannot find RH negative blood product? Yes, you can, provided that is his first time or her first time to receive RH positive blood. Succeeding transfusions throughout his life must be RH negative. Okay? Now, so the main issue here is RH incompatibility, correct? So if you go back to your blood types, you have type A, type B, type O, type AB. It could be A positive, A negative, B positive, B negative, right? So what I'm going to do now is I'm going to list all the different blood types and what blood can you give to a person, okay? So remember, type A has an antigen A, type B has antigen B, type O has no antigen, type AB has antigen A and B. Okay, so I will clear the board and we will see. So these are the different blood types. Different blood types. So we have type A positive, type A negative, type B positive, type B negative, O positive, O negative, AB positive, and we also have AB negative. So let's say that these patients will require blood transfusion. What blood can you give to this patient? Okay, what blood can you give? Okay, blood to give. Okay, so if the person's blood type is A, you can give A positive, A negative, O positive, O negative. Okay, if the blood type of a person is A negative, you can give A negative blood. You can also give O negative blood. If the blood type of the person is B positive, you can give B positive blood, B negative blood, O positive blood, O negative blood. If the blood type of the person is B negative, you can give B negative blood or O negative blood. If the blood type of the person is O positive, you can give O positive blood or O negative blood. If the blood type of the person is O negative, you can only give O negative blood to the patient. If the blood type of the patient is AB positive, you can give AB positive blood, AB negative blood. You can give A positive blood, A negative blood, B positive blood, B negative blood, O positive blood, and O negative blood. That's for AB positive. If the blood type of the patient is AB negative, you can give AB negative blood, A negative blood, B negative blood, and O negative blood. So you know now what blood type can be given to your patient. Now the question here, if you have this type of illustration and explanation, tell me, what do you think is the universal blood donor and the universal blood recipient? Remember, when you say donor, someone who gives the blood, someone who donates the blood, right? Ang nagbibigay. Now, I am Bisaya, I am from Doke, I am from Davao, so we have a technique used there. Pag nagbibigay ka, donor ka, di ba? So pag nagbibigay donor, O, type O. So the universal donor, blood donor is O. Recipient means to say that this is the person who receives the blood. The beneficiary of the blood, tumatanggap. Sa Bisaya, tumatanggap siya ang mudawat, ambi. That's AB. Okay? AB. So tell me, universal blood donor is O because regardless of the type of blood, you can give O, you can give O. But the question there is, what is the safest blood? Okay, let's change the color. I want to change my into color red. Look at the distribution. Regardless of the blood type, O negative can be given. O negative, O negative, O negative, O negative, O negative, O negative, O negative. Therefore, if you do not know the blood type of the patient, the safest blood is O negative. Okay? Why O negative? O, because that is the universal blood donor. Negative, because that means to say that the blood does not contain Rh antigen, right? So if a blood does not contain Rh antigen, there will be least likelihood to cause immune response or immune reaction. Therefore, that's the safest blood. Okay. Now, what about the recipient? You said AB, so it could be AB positive or AB negative. Check. What specific type of blood, AB blood, that can receive any type of blood? Answer, it's AB positive. Look, AB positive can receive any type of blood. So the universal blood recipient is AB positive. The safest blood is O negative. Okay? So well, ibig sabihin, Sir John, ang Rh incompatibility is common to Rh negative person. Correct. If you're Rh positive, you don't have issue. Why? Look. Hold on. So this is the person. Okay? This is, please bear with my drawing. So this is an Rh positive person. It means to say that the blood contains Rh antigen. Can you give Rh positive blood to this patient? Yes, because it has an Rh antigen. You can give a blood with Rh antigen. It doesn't matter because the patient himself contains Rh antigen. Can you give Rh negative blood to Rh positive patient? Yes, you can. It doesn't matter. You may give a blood with Rh antigen. You may give a blood without Rh antigen. It doesn't matter because of the fact the patient or the recipient K is Rh positive. Magiging issue lang siya if the person is Rh negative. I hope that is clear. Okay, now another thing. Another thing. Now, if this is your okay, if this is the RBC, okay, please bear with my drawing. RBC. Inside the RBC, there are molecules or pigments. Okay. Now you call these molecules or pigments inside the RBC as your hemoglobin. Okay. Your hemoglobin is a pigment responsible for, okay, carrying gases. The hemoglobin is actually divided into two. It has two parts. Hem, okay, hem and globin. Hem and globin. Hem, okay, hem and globin. In order for hem to be present, you need to have iron. Okay, that is why if you don't have iron, or if you don't eat foods high in iron, you will miss formation of hem. Without hem, hemoglobin is not formed. A decrease in the hemoglobin mass or decrease in the RBC count will result to a condition called anemia. You call that type of anemia now as iron deficiency anemia. And by the way, iron deficiency anemia is a form of hypochromic anemia. Okay. Now, what about globin? Globin to form, you need to have protein there. Okay. So if there is issue with the globin, hemoglobin is not formed, it will give you another disorder. Now, what do you call that disorder or a blood problem that greatly affects the globin? You call that blood problem as what you call thalassemia. Thalassemia. So it could be thalassemia major, thalassemia A, thalassemia B. I'm not talking about hemophilia. Okay, we're talking about thalassemia. Okay, I mentioned that hemoglobin carries gases. Correct. So what specific gas binds with the hemoglobin? So to be specific, hem, it is where oxygen binds. Globin, it is where your carbon dioxide binds. That is why if the patient is anemic, what is anemia? Anemia is a condition characterized by a decrease in the RBC count or a decrease in the hemoglobin mass. So regardless of the type of anemia, they share common issue or common problem. And what is that? Remember, there's several types of anemia. It could be anemia secondary to blood loss. It could be acute anemia or chronic anemia. It could be anemia secondary to nutritional deficiency. So if the anemia is nutritional deficiency, it could be iron deficiency anemia or a megaloblastic anemia. So when you say megaloblastic anemia, mega, large, blast cell. So there is large cell production. So why do we have large cell production? This is megaloblastic because the large cells there produced by the bone marrow is in response of nutritional deficiency. So megaloblastic anemia has two types. It could be a form of folate anemia or folic acid deficiency anemia, and the other one is your pernicious anemia. Okay, so these two are forms of megaloblastic. Or if you have anemia due to impaired RBC production. So if anemia is impaired RBC production, it could be a form of aplastic anemia or sickle cell anemia. So regardless of the type or classifications of anemia, they share one common issue. And what is that? Decreased oxygen carrying ability. So don't forget that. So lahat na pasyenteng may anemia, they have decreased oxygen carrying ability. Okay, so that is why you have to give auto supplementation to an anemic patient, or if not, we do blood transfusion. And I don't know what's your protocol in your hospital, but usually we do blood transfusion if the hemoglobin, if the hemoglobin of a person is less than 7. Okay. Anyway, let's continue. So that's it. I think this is the concept that I failed to share my screen, I think. And of course, meron pala isa. What was that again? Autonomic dysreflection. Autonomic dysreflection. This was another question a while ago. There's somebody who asked me about this and wants me to talk about autonomic dysreflection. So autonomic dysreflection is a complication of spinal cord injury. And there's another name for this. Autonomic dysreflection is also called autonomic hyperreflection. So what is this? It's a complication brought about by spinal cord injury, especially if you have a spinal cord injury above T6, thoracic 6. Okay, if you can still remember your spinal area, may mga pangalan yan. So you have your cervical, you have your thoracic, you have your lumbar. Am I right? So if you sustain spinal cord injury above thoracic 6, T6 and above, you will most likely end up having autonomic dysreflection. Okay, but take note, before autonomic dysreflection occurs, the patient will have spinal shock first. So ibig sabihin, spinal shock first. After spinal shock, you will have autonomic dysreflection. So what is spinal shock? Spinal shock is a medical term described as a sudden loss of spinal cord functioning. So what triggers autonomic dysreflection then? There are a lot of factors, but we can just simplify that into two. The first of the most common factor, sorry, nagbabasa ako ng mga comments. So far, wala namang comment. Smile, smile, smile lang at saka watching, watching lang. Okay. Anyway, the most common factor that can trigger autonomic dysreflection is a distended visceral organ. One common organ that will distend is your urinary bladder. So if you have a distended urinary bladder, it can trigger autonomic dysreflection. That is why one of your nursing responsibility for patient with spinal cord injury is to make sure that the patient has an indwelling catheter. So we do not limit catheterization. There must be an indwelling catheter to your patient. Not only distended bladder, another factor that can trigger autonomic dysreflection is physical stimuli. Example, accidentally naipit yung daliri ng pasyente sa side rail, or ayaw niya yung pillow, the pillow is so hard, or there is a fecal impaction, or the patient doesn't like the temperature in the room. Those are what we call physical stimuli. Okay, so management for your autonomic dysreflection, as mentioned, you need to promote urinary elimination, remove the physical stimuli, and sometimes we give medication to your patient. And one common medication here given is a drug called what's that? A drug called apresilin, or you call that sure hydralazine. Apresilin is a potent vasodilator. It will decrease the blood pressure of your patient. So, what manifestations of patient with autonomic dysreflection present? So, a patient with autonomic dysreflection or autonomic hyperreflection will present severe headache or throbbing headache. Patient may end up having seizures. Patient may have a nasal congestion, diaphoresis more on the forehead, pallor below the lesion. Patient, and we have several neurologic deficits. Okay, so it's all related to hypertension. So speaking of hypertension for patient with autonomic dysreflection, making sure that you elevate the head of the bed for patient with this type of condition, because failure to do that, remember, if the blood pressure of the patient is so high, that will increase the likelihood of the patient to end up having stroke. Okay. Now, what common type of stroke is attributed to persistent elevation in the blood pressure? That definitely is your hemorrhagic stroke. Why? Because if you fail to control the blood pressure of the patient, if the pressure is so high, the cerebral vessel will rupture. So you will have hemorrhagic stroke. Okay. It is not only autonomic dysreflection, a common complication of spinal cord injury. There are actually three common complications of SCI. First, there's your autonomic dysreflection. Second is orthostatic hypotension, or you call this as your postural hypotension. And third is your DVT or deep vein thrombosis. So these are three common complications of your spinal cord injury. Okay? I will not discuss those because hindi siya tinanong sa akin kanina. But if you with my students sa review, doon ko siya dinidiscuss yung mga Virchow's triad for your deep vein thrombosis. But anyway, so I think that's all for your autonomic dysreflection and then your blood. Okay, so at least wala na akong utang. It's my fault. I failed to share my screen, my monitor a while ago. So that's why I have to repeat this one. So I think I'm done. We will proceed to part 2 of your electrocardiography. Anyway, do you have any questions? Okay. Any questions? Any clarifications? Let me know. Hello, Sir Jeffrey Lesa. Okay. Please give me a few minutes. I'll just grab some water. Okay. Okay, let's continue. Okay, so just a recap about of our topic this morning, the part one of your electrocardiography. Where is that whiteboard? So I said that ECG or electrocardiography is a test that records electrical activities happening inside the heart. Okay, so I just want to make it clear, your EKG or ECG, ano ba yun, sir? Is it ECG or it's EKG? They're both correct. Okay, actually, what we uh, say is EKG. Why is EKG better than ECG? Because if you say ECG, 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 you may hear it differently. You may hear it as EEG. Okay, what is EEG? Electroencephalography. That's for the brain. So if you heard it differently, so chances are wrong diagnostic test is performed to your patient. So to prevent this mistake, to prevent that error, instead of saying ECG, you say that as EKG. Okay, so again, so EKG is a test that records electrical activities in the heart. Okay, it will not record contraction. I just want to make it clear. Your EKG records electrical activities, and there will be a graphic presentation of that or those electrical activities. And by the way, ECG is a form of dependent or independent nursing action. Long time ago, it's dependent. Okay, ngayon, it's an independent nursing action. So if a patient complains chest pain, respiratory difficulty, it's one of the nurse's discretion to put an ECG order for the patient. It's better to get an ECG once the patient is symptomatic. Okay, but by the way, is ECG 100% accurate? Answer no. The accuracy of ECG is about 70 to 80%. That is why if you have an ECG strip, you need to correlate that with the patient's clinical presentation. Okay, not only clinical presentation, uh, you need to correlate the ECG findings to patient subjective cues, objective cues, and other laboratory tests because, again, it is not 100% accurate. Okay, so that is why you need to develop a very important nursing skill assessment, a clinical eye. And of course, it doesn't happen overnight. It happens constant practice, reading a lot of literatures that are evidence based, update yourself. Okay. And let's go back. So when I say electrocardiography, again, it records there's graphic presentation of electrical activities. And those presentations or electrical activities are represented as waves. We have here the P wave, we have the QRS complex, then we also have the T wave. Okay. So I will not discuss this in detail. I already discussed this morning. Just a rundown lang. Okay. Ma-refresh tayo. So P wave represents atrial depolarization, correct? So QRS represents atrial repolarization and ventricular depolarization. The T wave represents ventricular repolarization. Okay? Can you write it down? Sure. So P wave represents atrial depolarization, depo. QRS represents atrial repolarization, and ventricular depolarization, and T wave represents ventricular hey, ventricular repolarization. Okay, we even had a simplified explanation about these waves this morning. Okay, so I want you to look at me. Okay, I want you to look at me and I hope this is clear. Okay, so remember I told you about the conduction system in the heart. Remember the SA node, the pacemaker. Okay, just a recap. Remember I said that this is the SA node, this is the AV node, this is the bundle of His, the right branch, left branch, and here will be the Purkinje fibers. Remember, I said that the SA node, once stimulated, eventually it can generate an electrical impulse, or some book we call it action potential. And because of that generation, this will lead to contraction of the right and left atrium, correct? As the right and left atrium contract, the impulse will travel and the impulse will go to your AV node. Once the AV node gets the impulse, the AV node will direct the impulse down. Okay, it goes to your bundle of His and then distributed to your right branch and left branch down to your Purkinje fiber. So technically, the direction of your impulse transmission, okay, in the heart is from the base down to apex. Okay, so remember, if you look at the monitor, I hope you can see the movement of the cursor. This is the base of the heart and this is the apex of the heart. I hope you can see that. Okay, so it goes down. So look, right and left atrium, right and left, tanggalin natin to. I want you to see me. So right and left atrium, right and left ventricle, right? Okay, right and left atrium, right and left ventricle. Anong sabi natin? Once SA node is stimulated, it can cause contraction of the right and left atrium. As the atria contracts, what did it tell you? As the atria contract, the impulse will travel going down. Okay, as the impulse traveled going down, no more impulse on top. The impulse is here in the ventricular area. As a result, if there's no impulse on top, the atria will relax. The ventricles will contract. Why did the ventricles contract? Because the impulse is there. After ventricles contract, the ventricles will relax. Hold on, may tanong. Can you please message me the part 1? Hi, Eliza Stewart. The part 1 is actually posted. It's posted sa Facebook page ko and sa page ng the Chronicle of Medical Surgical Nursing and page of US Review Center. Okay? I labeled that as electrocardiography. Anyway, so right and left atrium, right and left ventricle. Okay? So let's try to correlate this conduction system, these activities to your electrocardiography. Okay, SA node, AV node, bundle of His, right and left branches, Purkinje fibers. Now look, once SA node is stimulated, it can cause contraction of the right and left atrium. So this is your P wave, atrial depolarization. Okay, P wave. Okay, as the atria contract, the impulse will travel going down. So the impulse will travel going down, no more impulse on top. Impulse is here, causing relaxation of the atria, contraction of the ventricles. You call this as your QRS complex. Atrial repolarization, ventricular depolarization. QRS complex. Then after your ventricles contract, the ventricles will relax. So this is what we call T wave, ventricular repolarization. So P, QRS, T. P wave, QRS complex, T wave. P wave, QRS complex, T wave. P, QRS, T. P, QRS, T. P, QRS, T. Therefore, common sense will tell you that P, QRS, T is one heartbeat, correct? And again, what specific wave will represent the activity of the atria? P wave. P wave will represent the activity of the atria. What specific wave will represent the activity of the ventricles? QRS complex. QRS complex. So that is why, don't forget this in your NCLEX. Don't forget this if eventually be working in the bedside. If you want to check the status or the standing of the atrium of the patient or the atria, atrium singular, atria plural, you check the P wave. Okay. If you want to check the ventricles of the patient, look for the QRS complex. Okay. I hope that is clear. Now, let's go back. Okay, where is that whiteboard? Okay, I hope that is clear. Now, a standard ECG has 12 leads. Okay, a standard ECG has 12 leads, and these 12 leads are actually divided into two major leads. So you have your chest leads, and then you have your limb leads. Some book, they don't call this chest leads. Some book, they call this as precordial. Precordial leads. So this will be your V1, V2, V3, V4, V5, and V6. Okay? So leads placed on your anterior thorax, on your chest, are what we call precordial leads or vector leads, because letter V, vector leads or chest leads. Okay? Samantala yung mga electrodes placed sa extremities, case extremities, upper extremities, lower extremities, those are your limb leads. So we have there your AVR, you have there your AVL, AVF, okay? You have your lead 1, your lead 2, and lead 3, okay? What does AVR stand for? Augmented voltage right. That's on your right arm. Augmented voltage left. That's in your left arm. AVF is augmented voltage foot. So this is actually on your left foot. Yeah, I know, left foot. But sir, there's another there's another lead placed on your right foot. Yes, the right foot. The thing being placed there is your ground. There's a ground. Now remember, I said these are your 12 leads. Now, what is the relevance or what is the importance of your K12 lead EKG? Your 12 lead EKG is done for diagnostic quality or diagnosing patient. Okay? That is done for diagnosing patient. Okay, now what is the importance of your 12 lead EKG? Let's try to use this one. Okay, here. So this is the relevance of your 12 lead EKG. Everybody look at me. So this is a Rubik's Cube. Okay? So all of you, okay, you can see the front part of the Rubik's Cube. Okay? If I am in my actual review class, so usually pag nagre-review ko ang daming estudyante, may mga estudyante sa side, may mga estudyante sa other side. So if you're seated on this side, on my right side, you can see this part and the right side of the Rubik's Cube, but you cannot see the back part. If you're seated on this side, you can see this side of the Rubik's Cube and you can see this side, but you cannot see the back part. All of you facing me, you cannot see the back part of the Rubik's Cube. You cannot see the top, okay, and the lower part of the Rubik's Cube. So what is the relevance of your 12-lead EKG? The 12-lead EKG are the different views of the heart, okay? Different views of the heart. That is why with your 12-lead EKG, you will have an overall picture of the heart. You can see where is the enlargement. Is it on the right side? Is it on the left side? You can see where is the infarction. Is it on the lateral area? Okay, you can see what chamber is having hypertrophy. Is it the atrial chamber? Is it the ventricular chamber? Because that 12-lead EKG will give you the overall picture of the heart. That is the relevance of your 12 lead. That is why your 12 lead EKG is done for the purpose of diagnosing patient. Okay, because we can also put K electrodes on the chest for the purpose of monitoring, not diagnosing. Okay, just like in your ICU, when you put the patient in cardiac monitor, that's the purpose there is for monitoring quality, not diagnostic quality. Anyway, let's continue. So among the 12 leads I mentioned a while ago, now what do you think is a specific lead that is so helpful? Okay, the specific lead that is so helpful is your lead 2. Why is lead 2 so important in your 12 lead EKG? Because of the fact that among the leads, your lead 2 is said to be the most stable lead. Okay, most stable. That is why if it is the most stable lead, this is the lead you check if you want to read the heart rate of the person. Since it is the most stable lead, this is the best lead to check for any dysrhythmia or arrhythmia. Okay, that is why if you notice, there are doctors who will order for 12 lead stat EKG with long lead 2 strip to chart. So they will order for a 12 lead EKG and a long tracing of a 12 lead, and then the strip is placed in the chart because they want to check it later. Okay, so they ordered for a long lead 2 because again, it's the most stable. Okay, so in the actual review, I will teach you where to place the V1, V2, V3, V4, V5, V6, and all the placements of this limb leads as well. Okay, but since this is just an overview of your electrocardiography, mabilisan tayo at i-discuss ko yung mga common lang at saka importante. Okay, now I want you to check the sample leads here. So this is a sample of a lead. I don't know if you can see this one. Okay, here. So I said that an ECG tracing is written in an ECG strip, and an ECG strip is composed of small boxes and big boxes. Don't forget that the borders of the big box are always darkened. So this is your big box, okay? And inside the big box are small boxes, okay? So there are 5 small boxes in one big box, okay? And don't forget that one small box is equivalent to 0.04 second. One small box is 0.04 second. I did not say 0.4. Okay, 0.4 is different from 0.04. Okay, so if one small box is 0.04 second, how many second will it be if you have two small boxes? That will be 0.08. What about if you have 3 small boxes? 0.04 times 12, the product will be 0.12 second. What about if you have 5 small boxes? That will be 0.20 second. So again, one small box is 0.04 second. One big box is 0.20 second. Why? Because one big box has 5 small boxes. Okay? And I said the borders of the big box are always darkened. Okay? And one small box is 1 millimeter, 1 mm. Okay? So how many millimeters if you have one big box? So that will be 5 millimeters because again, there are 5 small boxes in one big box and one small box is 1 mm. Okay, look at the upper part of this ECG strip. Can you see this dark line here? This dark line is important because that if you connect this dark line to another dark line, the distance from this dark line to another dark line is actually 3 seconds. So if you have 3 of this, 1, 2, 3, so this will be 6 seconds. So this is a form of a 6-second strip because from this grid, from this line to this line is 3 seconds. And another 3, so that will give you 6 seconds. So I hope that is clear. Okay? So this is your ECG. Okay? So look at the different waves. So you have the P wave. Okay, this is your atrial depolarization. This is your QRS complex. And the QRS complex represents atrial repolarization and ventricular depolarization. Then you also have your T wave. T wave represents ventricular repolarization. Okay? And I told you about the small boxes and the big box. Again, one small box is 0.04. One big box is 0.20 second because again, 5 small boxes. Now, these are the values that you need to remember for your examination. The heart rate, the PR interval, and the QRS complex. Okay? The normal heart rate ranges from 60 to 100 beats per minute. Okay? If the heart rate is more than 100, that is tachycardia. If the heart rate is less than 60, you call that as bradycardia. I told you this morning that there are people normally bradycardic, especially if they are elderly and especially if they are athletic people. Okay, bradycardia is an issue if the patient is symptomatic. Okay, and what else? Take note of the normal PR interval and the normal QRS complex. The normal PR interval is 0.12 to 0.20 second. So how many boxes will that be? So this will be 3 to 5 small boxes. 3 to 5 small boxes. So, saan ba nagsisimula yung PR interval? Remember, this is your P. So magsisimula ang PR interval from the beginning of the P wave and right before the QRS complex. So how many boxes how many boxes are this? 1, 2, 3. So 0.04 times 3, that's 0.12. Okay, so how many boxes ang normal PR interval? That's 3 to 5 small boxes. Please be reminded, if the PR interval is prolonged or more than 0.20 second, you suspect AV block. Okay, you suspect AV block. Now next, normal QRS complex. I said you suspect. Okay, hindi ko sabing that is confirmed AV block. Baka mabash na naman tayo. Okay? Next, QRS complex. The normal QRS complex is 0.08 to 0.12. So how many boxes will that be? That will be 2 to 3 small boxes. So where's your QRS complex here? So this is your QRS complex, the beginning of the QRS and the end of the QRS. So this is your QRS complex. How many boxes? 1, 2. So 0.04 times 2, that will be 0.08. So that's normal. So there will be 2 or 3 small boxes for your QRS complex. Hey, Mom Sheila, how are you? So I hope this is actually clear. Okay? I hope this is clear. Now, what I'm going to do now is I'm going to give you the outline of common ECG tracings, and we will talk about medications given to your patient. Okay? Where is that? Whiteboard. Okay, here. So when I say medications, so what are common antidysrhythmic medications, antidysrhythmic drugs? So what are the different antidysrhythmic medications? There are actually 4 classes of antidysrhythmic drugs. Okay, I need to discuss this first para dire-diretso na tayo mamaya. Okay, so you have your class 1, you have your class 2, you have your class 3, and then you have your class 4. Okay, your class 1, you call this as your sodium blockers. Your class 2, you call this as your beta blockers. Class 3, this will be your potassium blockers. And that's your class 3. Class 4 will be your calcium blockers. Okay? So class 1 is your sodium channel blockers or sodium blockers. So let's begin with your class 1. Okay, so if you have class 1 antidysrhythmic drugs, so you have to consider, what do you think is the best antidysrhythmic to patient with atrial dysrhythmia? Okay, what do you think is the best antidysrhythmic to patient with ventricular dysrhythmia? Okay, so don't forget this. A patient with atrial dysrhythmia, so we say atrial dysrhythmia, it could be atrial flutter, atrial fibrillation. So an atrial dysrhythmia, the first line drug given here is a sodium channel blocker, and that will be your PQ. Hey, what happened? Hey, PQ. So you have your PQ. Okay, PQ. What's PQ? P stands for procainamide. And Q stands for your quinidine. Quinidine. So procainamide and quinidine are examples of a sodium channel blockers best given to patient with atrial dysrhythmia. But for patient with ventricular dysrhythmia, okay, common drug given here is your lidocaine. Oh, is lidocaine, is that your local anesthetic, your xylocaine? Yes, that's your lidocaine xylocaine. Remember, your lidocaine xylocaine is not just a local anesthetic drug. It is also antidysrhythmic, especially if that lidocaine is pure. If a lidocaine contains preservative, if a lidocaine contains epinephrine, then most likely that is a lidocaine said to be local anesthetic. But if it does not contain, if it has no preservative, that is your antidysrhythmic. So how can lidocaine act as an antidysrhythmic medication? Your lidocaine will decrease the permeability of the sodium channel blockers in the membrane. So as a result, if it decreases the permeability of sodium channel blockers, the the contraction is actually inhibited. Okay, or the contraction, sorry, wrong choice of word. The conduction is inhibited. So that acts as an antidysphoretic medication. Okay? Class 2, okay, class 2 will be your beta blockers. Beta blockers. So when you say beta blockers, these are drugs ending in olol, just like your metoprolol, propranolol. Don't forget in your NCLEX that your beta blockers, okay, that your beta blockers, you have to check patient's blood glucose level, blood sugar. Why? Because beta blockers may mimic hypoglycemia. Okay, it may give you a presentation that the patient is hypoglycemic, or in fact, it's not. Okay, that's the side effect of your beta blocker. What else? Patient taking beta blocker, one common reason of non-compliance is that the beta blocker can cause sexual dysfunction. It can cause erectile dysfunction. And what is that? It can cause impotence. So don't forget that. That's one reason why a person will stop taking beta blocker because of sexual dysfunction. Okay, and that is impotence. Next, if your patient beta block is receiving beta blocker, don't forget that the most fatal side effect of beta blocker is bronchospasm. What makes bronchospasm fatal is that it can lead to airway obstruction. Having said that, there will be airway obstruction, we cannot give beta blocker to patient with asthma or having asthma attack because again, it exacerbates or not exacerbates, it worsens airway obstruction of the patient. Okay, that's your beta blocker. And of course, remember beta 1, beta 2 adrenergic blocking agent. Make it sure that you count the heart rate of the patient in 1 full minute. Never give beta blocker if the heart rate of a child is less than 100. Never give beta blocker if the heart rate of an adult is less than 60, because again, it causes bradycardia. Never give beta blocker if the blood pressure is less than 90/60. Okay, anyway, didn't discuss nothing in detail in the actual review. Okay, next, number 3, your class 3, we have your potassium blockers. Potassium blockers. So one good example here is your amiodarone. Okay, amiodarone. Now do not forget this in your NCLEX. Amiodarone is a class 3 antidysrhythmic that causes bluish discoloration of your skin. Okay? Saan? Skin exposed to sunlight. Okay? So there is somehow a photosensitivity. It causes bluish discoloration of the skin exposed to sunlight. Thing to remember with amiodarone is that do not give an herbal med to patient taking amiodarone. Now, what specific herbal med, herbal med that you have to avoid? Answer is your St. John's wort. Okay. Why is it we discourage you giving St. John's wort to patient taking amiodarone? Because it decreases the effect of your amiodarone if you're taking St. John's wort. Okay. That's your beta. That's your potassium blockers. Next is your class 4, and that is your calcium blockers. Calcium, hold on. May nagme-message. Okay, RJ de la Victoria. Thanks, Sir John. Okay. Don't worry, RJ. I find ways and time if you want me to discuss all these concepts. Okay, ang dami nun ah. Okay. Okay, let's proceed. So calcium blockers. So give me example of calcium blockers. Remember your technique there. What specific vitamin is needed to enhance calcium absorption? Is it for calcium? Is it your vitamin D? Vitamin D? Yes. So this is your technique in your NCLEX. VD, VD are examples of your calcium blockers. V stands for your, not vitamin D, verapamil. Verapamil. And D stands for diltiazem. Okay, diltiazem. So VD. So these are examples of your calcium blockers. Calcium blockers. Anong dapat tandaan? If your patient takes calcium blockers, just like your beta blockers, never give this if the heart rate of a child is less than 100. Never give this if the heart rate of an adult is less than 60. Do not give this if the blood pressure is less than 90 over 60. Okay? And take note, patient taking these drugs, okay, patient taking these drugs, do not give grapefruit juice. Remember, in medical surgical nursing, it is our it's our mortal enemy. Okay, a grapefruit juice is our mortal enemy. Okay, this is not grapes. Magkaiba po ang grapes and grapefruit juice. Okay, different. Why you do not give grapefruit juice to patient taking calcium blockers? Because if you do, it potentiates hypotension. Okay, it worsens hypotension to your patient. So these are the different antidysrhythmics that you have to remember in your examination. Okay, so let's proceed. So what I'm going to do now is I will name the common tracing. I will describe them one by one. And then after that, I will show you the picture, and then so that you can easily remember what I am talking about. Okay. So what are the different tracings that you will discuss tonight, Sir John? So I will describe sinus, I will describe your normal sinus rhythm. Then we will talk about sinus tachycardia, tachycardia. Then we will talk about sinus bradycardia. Then after that, we will talk about atrial dysrhythmia. So when you say atrial dysrhythmia, I will discuss atrial flutter. I will talk about atrial fibrillation. Okay. Then after that, we will talk about ventricular dysrhythmia. So ventricular dysrhythmia, we will talk about ventricular tachycardia. We'll talk about ventricular fibrillation. Idagdag na rin natin ang PVC, your premature ventricular complex or premature ventricular contraction. Then I will also include torsade de pois. Your torsades de pointes, but you will say that as torsade de pois. And then I will also talk about asystole or asystole. Then we will talk about your AV block. Okay, these are common tracings, right? And your AV block is divided into 3. So you have your first degree. So you have your second degree. Then we also have the third degree AV block. Another name for third degree AV block is your what? This is your complete heart block. By the way, the second degree block, the second degree block is subdivided into 2. So we have here your Mobitz 1, and then you have here your Mobitz 2. So this is the outline of my topic. Okay, so what I'm going to do here is I'll describe them, okay, one by one, and I will give them the drug of choice, what medication will be given to your patient, and what are possible procedures. I'm telling you, there are several tracings. We even have the right bundle branch block, left bundle branch block. Ang dami pa po. Junctional rhythm, supraventricular tachycardia, ang dami pa po, but I will only discuss the common. We even have this what we call PEA. I'm not sure if you're familiar with PEA. That's PEA. Okay. Anyway, so usually I discuss that in the full review program. Okay. So I will just discuss these common tracings. Okay. So let's try to clear the board and discuss them one by one. Okay, so first is what we call the normal sinus rhythm. So when you say normal sinus rhythm, take note that the heart rate is normal. So you say normal heart rate, it ranges from 60 to 100. Okay? A normal sinus rhythm has a complete waves. So when you say complete waves, we have P wave, we have QRS complex, and the T wave. Okay? P wave, QRS complex, T wave. Remember, if I'm going to draw this one, the waves, you have the P wave, Q, R, S, T. Okay? So this is the P wave. This is the Q. This is the R. This is your S. And this is your T. Remember, there is one P wave before QRS, and there is one T wave after QRS. After T wave, you will have another P wave. Q, R, S, T. Okay, so you know that in every QRS, there is one P wave and there is one T wave. Okay, P, Q, R, S, T. One P wave in every QRS and another T wave every QRS. And the T wave is followed by a P wave. Okay, if you look at it, there is an invisible line here. You call that as your isoelectric line. That mark is so important to evaluate whether the ST segment is elevated, ST segment, or depressed ST segment. Anyway, I usually discuss that's a review. Here, so a normal sinus rhythm has a normal heart rate, waves are complete, and take note with rhythm, okay? And take note you have a normal PR interval, okay? So this is the description of your normal sinus rhythm. But for sinus tachycardia, okay? Sinus tachycardia, a heart rate here is greater than 100 beats per minute. And guess what? Waves are complete. Complete waves. Take note with rhythm. Oh. And you have a normal PR interval. So the only difference here with your normal sinus rhythm and sinus tachycardia is the heart rate. If the heart rate is greater than 100, that's sinus tachycardia. Okay? Tell me, a patient with sinus tachycardia, okay, what are common meds given here? So usually we give beta blockers. Beta blockers. You can also give calcium blockers. Okay? Beta blockers, these are your beta adrenergic blocking agent. Okay? Now, common beta blocker here is your beta 1 blocking blockers because beta 1 is for the heart, beta 2 is okay, that's for your lungs. And we also have a non-selective beta blocker. But anyway, beta blocker is given. And there is a procedure done that will decrease the heart rate of your patient. And we call that as your what? Carotid massage. Your carotid massage is done in order to decrease the heart rate because doing carotid massage, if you can see me, I don't think so. I don't think so. If you do carotid massage, if you can see me, if you do carotid massage, the effect is that it can cause vagal stimulation. Okay. And that vagal stimulation will decrease the heart rate of the person. And that's the same reason why when we do suctioning, apparently when you do suctioning, there's a risk of vagal nerve stimulation. So if you suction the patient and you happen to see in the cardiac monitor during suctioning, the heart rate decreases, what will you do? Okay, stop suctioning and hyperoxygenate your patient. Okay, that is due to vagal stimulation, vagal nerve. Imelda Hover, sir, very informative talagang lecture mo. Kaso lang putol-putol yung signal ko. I'm so sorry to hear that. So I think we really have to improve our internet service in the Philippines. Okay, let's proceed. Okay, so that's your carotid massage. That's your sinus tachycardia. Now, what about for your sinus bradycardia? Let me clear this board. Sinus bradycardia. Bradycardia. So if it is sinus bradycardia, of course, we know that the heart rate here is less than 60 beats per minute. That's bradycardia, correct? And the waves are complete. Oh, complete waves. And guess what? With rhythm, and guess what? You have a normal PR interval. Okay, that's your sinus. So the only difference is that the heart rate. Okay, so if the heart rate is normal, 60 to 100, that's normal sinus rhythm. If the heart rate is more than 100, that's your sinus tachycardia. If the heart rate is less than 60, that's sinus bradycardia. Okay, and what do you think is the common medication given to patient with sinus bradycardia? We usually give what medication? A drug, of course, that will increase your heart rate. Okay, and what medication will increase the heart rate of your patient? So we give here your atropine. Atropine. Don't forget your atropine will increase your heart rate. Okay? Atropine will increase your heart rate. I hope you're familiar with atropine sulfate. And by the way, this morning, a student requested me to discuss pharmacology. Okay? And I made a promise and I said yes. So one of these days, I will go live again and I will talk about pharmacology. And I told them my approach in discussing pharmacology is per system. So we'll talk about neuro and then what common drugs are given during or to patient with neurologic disturbances, respy, what medications are given, cardio, what medications are given. Okay, so that will be my approach. Just watch out for that. Okay. Okay, so this is your sinus bradycardia. Next is your atrial dysrhythmia. Dysrhythmia. Nakakaloka yung spelling ko ah. Okay. So atrial dysrhythmia, I said that a patient with atrial dysrhythmia, we give antidysrhythmic drug. You have your PQ. Remember PQ? So what are this? You have your procainamide, and then you have your quinidine. I said that this antidysrhythmic class 1 is best given to patient with atrial dysrhythmia. And there's one more thing. A patient with atrial dysrhythmia will have a risk of stroke. We know that, okay? There is always a risk of stroke. Why? A patient with atrial fibrillation, okay, or atrial dysrhythmia, pwede po magtapon yung heart natin ng clot. And when the heart now throws clot, an emboli, and that emboli enters the cerebral circulation, it causes thromboembolic stroke. So apart from your procainamide and quinidine, you can also give anticoagulants. You can also give antiplatelets. Okay, so you can give aspirin. Okay, you can give Eliquis. Eliquis is the brand name. The generic name is Apixaban. Correct me if I'm wrong. Apixaban. Parang ganun. It sounds like that. Okay? But I know that it's an Eliquis. Okay? Aspirin. Aspirin is an antiplatelet. By the way, what is the difference between anticoagulant? Yeah, heparin is an anticoagulant. Very good, RJ. Okay, but we don't give that as a maintenance dose to your patient. Apixaban, yun. Thank you so much, RJ. Sabi ko, it sounds like apixaban, apixaban. Nakakahiya. But anyway, pero tama ako dun ah. So, Eliquis. So, by the way, what is the difference between anticoagulant and antiplatelet? Okay, an antiplatelet is different from anticoagulant. An anticoagulant, by its mechanism of action, is that an anticoagulant prevents clot formation. It prevents clot formation. An antiplatelet is different. An antiplatelet prevents platelet to form a clot. Okay? It prevents platelet to form a clot. That's an antiplatelet. An anticoagulant prevents clot formation. It is also different from your thrombolytics. Your thrombolytics are called clot busters. So they will dissolve the clot. Example of your thrombolytics are your TPA, that's your tissue plasminogen activator, Another example is your streptokinase or streptokinase. Okay, so they're different. Anyway, your aspirin, don't forget, is a gastric irritant. So you gotta watch out for bleeding if your patient takes any of these drugs. And of course, in the actual review, I discussed this one by one. Common question there: when will you discontinue aspirin prior to surgery? When will you discontinue heparin? When will you discontinue warfarin prior to surgery? What is the best diagnostic test for your aspirin? Diagnostic test for your heparin? Diagnostic test for warfarin? The antidote for aspirin? Antidote for heparin? Uh, mga ganung klaseng tanong, yung mga INR, PTT, cutting time, heparin anti-XA, ano pa ba yung mga dinidiscuss natin sa review. And of course, yung mga tinatawag nating therapeutic level at saka normal level. Remember that the therapeutic level must be 2 to 2.5 times higher than the normal level. Anyway, so that's it. So that's your atrial dysrhythmia. So you have your procainamide, quinidine, and some anticoagulants, antiplatelets. Because I said atrial dysrhythmia will increase the likelihood of stroke. So when I say antidysrhythmia, there are two common antidysrhythmias you need to remember. So first is what we call atrial flutter. Atrial flutter. So how would you describe atrial flutter, Sir John? Okay, an atrial flutter, okay, take note, an atrial flutter is a tracing with rhythm, okay, with rhythm. An atrial flutter, don't forget that the P wave looks like sawtooth in appearance. Okay, sawtooth in appearance. Sawtooth appearance is the classic feature of your atrial flutter. And an atrial flutter, take note, with QRS complex. Okay, with QRS complex. Now, what about atrial fibrillation? Okay, atrial fibrillation, take note, there is no rhythm. Okay, no rhythm. And there is no specific P wave. But guess what? It has QRS complex. Okay, let me just remind you, these are my techniques to help me identify ECG tracings. If you have other ways, that's also fine. If you were taught by other lecturer or other, you had some coaching before, that's also fine. But for me, this tips will help me identify tracing a little bit faster and easier. So an atrial fibrillation, no rhythm, no specific P wave, but there is what we call QRS complex. Okay, and take note, I said for your atrial dysrhythmia, I mentioned you give procainamide, you need quinidine, and you may give aspirin. And take note, additional management for your atrial dysrhythmia is that we do cardioversion. Cardioversion. Your cardioversion is different from your defibrillation. What is the difference between cardioversion and defibrillation? First, in cardioversion, when we deliver shock, it is specific, okay, to a specific cardiac cycle. And usually, not usually, in your cardioversion, we give shock specific to your QRS complex, to your R wave specific. But in your defibrillation, we can deliver shock anytime in the cardiac cycle. Okay, another difference. In cardioversion, we use a low energy, a low voltage, not voltage, a low energy. Usually, we start at 50 joules in cardioversion. Samantala, in defibrillation, we use a higher energy. Usually, we start at 200 joules. So having said that, mas mataas na energy ang ginagamit sa defibrillation. That is why defibrillation will most likely cause skin injury, burn injury, compared to your cardioversion. And cardioversion is performed as a form of elective procedure. It can be scheduled. Okay? And samantala, ang defibrillation, it's an emergency condition. And what else? Patient with defibrillation is unconscious. Samantala, in cardioversion, initially the patient is conscious and then we sedate the patient for cardioversion. And speaking of sedate, the most common medication given to sedate the patient for cardioversion is a drug called propofol. That's a common medication here. So propofol is a form of a fast but short-acting sedative. Fast but short-acting sedative. It's propofol. And when you give propofol, sometimes patient will complain of a burning sensation. Anyway, so this is your atrial flutter, atrial fibrillation. Okay, I hope this is clear. Next, we have your ventricular dysrhythmia. Ventricular dysrhythmia. Dysrhythmia. You are correct, RJ. Okay, you are correct. Ventricular dysrhythmia. Okay, now, example here will be your ventricular tachycardia, your VTAC. Your ventricular tachycardia is a deadly dysrhythmia. Do you know that? Ventricular tachycardia. Ang kati nito okay? Ventricular tachycardia. So how we describe ventricular tachycardia? So remember tachycardia, the heart rate is greater than 100. Okay, anyway, the best description for me for ventricular tachycardia is that, okay, the tracing is actually wide and the tracing is actually bizarre. Okay, wide and bizarre, and take note, okay, with rhythm. Oh, may rhythm siya. Taray So that's your ventricular tachycardia. Wide, bizarre, with rhythm. Okay, and for patient with ventricular fibrillation, bago ko makalimutan, ano pala ang common meds na binibigay natin dito? Okay? Common meds na binibigay natin for patient with ventricular problem is, of course, you have your lidocaine, okay, lidocaine, and apart from lidocaine, you also give magnesium sulfate or your magnesium. So what is the purpose in giving magnesium to patient with ventricular dysrhythmia? The reason why we give magnesium is to prevent development of a polymorphic ventricular dysrhythmia. So when you say polymorphic ventricular dysrhythmia, I am referring to your torsade de poids or your torsades de pointes. That's the reason why we give magnesium. Okay? Now, apart from your medication, you can also do defibrillation. Okay? Now, specific for your ventricular tachycardia, okay? Do we defibrillate ventricular tachycardia? There are two parameters you have to consider. If a patient with VTAC, okay, has pulse, then we do cardioversion. If a patient with VTAC has no pulse, pulseless, then we do defibrillation. Okay, let's proceed. What about ventricular fibrillation? In ventricular fibrillation, how would you describe this tracing? This tracing is chaotic. This tracing is disorganized. Okay? And take note, in ventricular fibrillation, without rhythm. No rhythm. And to treat patient with ventricular fibrillation, we usually have an approach. What is the usual approach in treating patient with ventricular fibrillation? We usually do DILM. DILM. What's DILM? D stands for defibrillation. E, we give epinephrine. A, we give amiodarone. L, we give lidocaine. And M, we give magnesium. Remember the reason why we give magnesium? To prevent torsade de pois, to prevent development of a polymorphic ventricular dysrhythmia. And that ventricular dysrhythmia is what we call torsade de pois. Okay? That's your ventricular fibrillation. Next. Next is your PVC. That's your premature ventricular complex or premature ventricular contraction. How will describe this tracing? There is no P wave. Okay, there is automatic QRS complex. And guess what? Okay, it is followed by compensatory pause. There is a compensatory pause after the PVC. Wag na wag kalimutan sa NCLEX exam that a patient with premature ventricular complex, a PVCs of more than uh, three PVCs in a row, or more than 6 PVCs in 1 minute. Okay, it may indicate a pending cardiac arrest. And guess what? A PVC of 3 consecutive can be called a VTAC. Okay? 3 consecutive PVCs can be called as a VTAC. 3 PVCs in a row. Remember, VTAC is a deadly dysrhythmia. Okay, don't forget that. But not all PVCs of more than 6 PVCs in 1 minute, okay, is a pending cardiac arrest. Why? There are patients that PVC is normal for them, especially if they have an existing cardiac issue or cardiac abnormality or cardiac problem. Okay, but nevertheless, you have to take in consideration these parameters. But again, there are those who has an existing PVCs and that's not an issue for them. Kasi nga they have an existing cardiac abnormality. Okay? Next is your asystole or asystole. So you call this as your flat line. Okay? In short, no specific wave or waves. Never forget this in examination. A patient with asystole, you have to do CPR. Okay? Do CPR. I hope you're familiar with your ACLS. Okay? You do CPR. Okay? I hope you can still remember the new pattern now for your CPR. That's your CAB. Okay? Compression, airway, and breathing. Dati-dati we start with airway, correct? So ngayon hindi na. We start with compression. And when you compress, remember the statement, compress, do compression fast and hard. Okay? More than 100. I hope you can still remember the song. What song was that again? A song from Bee Gees. Stay alive, ha, 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 stay alive. I think that's the rhythm you have to follow when you do CPR. Stay alive, ha, 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 ha. Okay, anyway, I look crazy. So anyway, that's your CPR. And remember, you have to convert asystole into ventricular dysrhythmia, or, okay, otherwise you cannot do defibrillation. So take note, in asystole, do not defibrillate. Okay? Do not defibrillate asystole. Why? You need to convert this to ventricular dysrhythmia. If you cannot convert this to ventricular dysrhythmia, you have to continue with your CPR. Okay? Continue with your CPR and medicine. Okay, and once you convert this into this ventricular dysrhythmia, then you have to evaluate, is it shockable or non-shockable? Okay, so that's the time you can defibrillate, but technically we cannot defibrillate asystole. Okay, it's your flat line. Okay, I hope this is clear. Next, you have your AV block. Do you have any questions? I hope so. Okay, so you have your AV block. Let's begin with your first degree. Okay, so in first degree AV block, don't forget that a first degree AV block, okay, complete waves. In your first degree AV block, take note with rhythm. Okay, in your first degree AV block, don't forget consistent that the PR interval is prolonged. Okay, the PR interval is actually prolonged. It's your first degree AV block. Second degree AV block, Mobitz 1. Ayan. Second degree AV block, Mobitz 1. Don't forget, waves are also complete. Complete waves with rhythm. And take note, in second degree AV block, Mobitz 1, don't forget that the PR interval gets progressively longer. Okay, remember, what is the normal PR interval? I said the normal PR interval ranges from 0.12 to 0.20. So that will be 3 to 5 small boxes. And in your second degree AV block Mobitz 1, the PR interval gets progressively longer. Okay? Next, we have here your second degree AV block Mobitz 2. Okay? Second degree AV block Mobitz 2, usually you have more than one P wave in every QRS complex, or if not, okay, it has a rhythm, or tandaan, second degree AV block, don't forget that the PR interval, okay, is normal using P wave near QRS complex. Okay? I will explain that in a bit. Third degree AV block, take note. Almost the same with your second degree AV block Mobitz 2 with rhythm more than one P wave in every QRS complex. Look at the PR interval. PR interval is inconsistent. When you say inconsistent, it could be normal or it could be prolonged. Okay? I hope that is clear. So let me draw this one. So remember, this is the normal. P, Q, R, S, T. So this is the P wave. This is the QRS, ano ba yan? QRS complex. This is your T wave. Remember from, let me change the color. Okay. Remember the PR interval will be from this part to this part. So this is your PR interval. Okay, this is your PR interval. That's the normal PR interval will be 3 to 5 small boxes. Correct? That's the normal. In your first degree AV block, waves are complete. You have the PQRST with rhythm, but the PR interval is prolonged. It looks like this. P, so this is your P, this is your Q, R, S, T. P, Q, R, S, T. The PR interval is prolonged. PR interval is prolonged, but the waves are complete and it has rhythm. The RR interval is consistently the same. Okay, that is your first degree AV block. But for your second degree AV block Mobitz 1, waves are complete with rhythm. It's just that the PR interval gets progressively longer. So it may look like this. P, please bear with my drawing. Did you notice this? Okay. Did you notice the decay? It gets progressively longer. So that is your second degree AV block Mobitz 1. But for your second degree AV block Mobitz 2, possibly po na more than one P wave in every QRS. My rhythm is just that the PR interval is normal. So it may look like this. P, Q, R, S, T, another P, P, Q, R, S, T, P, P, Q, R, S, T. So another, this is P wave, this is your T, this is P number 1, this is P number 2, this is your T, this is P number 1, this is P number 2. Normally, there's one P wave in every QRS. What happens here is that there's more than one P wave, more than one P wave in every QRS. But if you use the P wave near to your QRS, the PR interval is normal. But if you use the P wave far from the QRS, of course, it's prolonged. But if you use the P wave normal, if you use the P wave near to your QRS complex, then that is your Mobitz 2. But in your third degree AV block, almost the same with your second degree, but it's inconsistent. Sometimes it's prolonged, sometimes it is it's prolonged, sometimes it's normal. So the only difference between second degree AV block, Mobitz 2, and third degree AV block is the PR interval. In Mobitz 2, the PR interval is normal. In third degree AV block, the PR interval is inconsistent. Okay? Sometimes prolonged, sometimes normal. Okay? I hope that is clear. Now, I will show you the picture now, how they look like. Okay. Your questions are can be answered on these slides. PowerPoint. Okay, here. So this is your normal sinus rhythm. Okay? So look at the waves. This is the P wave. This is your Q, R, S complex, and the T wave. P, Q, R, S, T. So in short, a normal sinus rhythm is a tracing or a rhythm wherein waves are complete. Okay? Waves are complete and it has rhythm. Look at the R wave and R wave. The distance of this R to R is identical. Ibig sabihin, pare-pareho yung distance nila. In short, may rhythm sila. Correct? And the heart rate is within the range of 60 to 100. How will you read the heart rate of your patient with this? Remember the rule? If it is a 6-second strip, you count the number of R waves and you multiply that by 10. Whatever is the product, that's the heart rate in a 6-second strip. But if you don't have a 6-second strip, how will you know the heart rate? You count the interval between R to R wave. So if this is the R wave that falls directly as a dark line, okay, and this is the next R wave, you start counting. Okay, how will you count that? You don't count that 1, 2, 3, 4, 5. No. So the numbers to memorize here are the 6 numbers 300, 150, 100, 75, 60, 50. Ano daw yun? Okay, let me write it. Okay, so these are the 6 numbers. So you have your 300, 150, 100, 75, 60, and 50. So these are the 6 numbers you need to familiarize if you want to read the heart rate of the patient without using the 6-second strip. Okay? Kasi sabi ko nga, if it is a 6-second strip, all you have to do is to count how many R waves and you multiply that by 10. So that is the heart rate of the person or the patient. But if not, then you have to use the 6 magic numbers. 300, 150, 100, 75, 60, 50. So let's go back. So look at the R wave or find an R wave that falls directly to dark line. Remember what did I tell you? The borders of the big box are always darkened. Okay, so this is an R wave. I hope you can see that the cursor is moving. So this is an R wave. This is an R wave that falls directly to dark line. And this is the next R wave. This is the next R wave after this. So an R wave that falls directly to dark line is your base. And the next dark line, this is the next dark line, right? Hey, didn't do anything. The next dark line, okay, the next dark line, you start counting. So R wave that falls directly to dark line, the next dark line you count 300, 150, 100, 75, 60. Again, R wave that falls directly in a dark, ano ba yan? Sorry, napapress kasi siya sa R wave that falls directly to dark line, the next dark line you start counting 300, 150, 100, 75, 60. This R wave falls directly between 60 and 75. This is 60, this is 75. It's between 60 and 75. That's the heart rate, 60 to 75 beats per minute. Is that normal? Yes, it is. If this R wave falls directly here, then the heart rate is exact 75 beats per minute. Okay, sorry. The slides keeps on moving. Okay, so that's normal because the normal is 60 to 100. Look at your PR interval. The PR interval is 3 to 5 small boxes. This is your P and this is your QRS. So 1, 2, 3, 4. There are 4 small boxes because the normal is 3 to 5. So in short, a normal sinus rhythm is a tracing wherein waves are complete, heart rate is within the range, PR interval is normal, and it has rhythm. Okay? This is your sinus tachycardia. Look at your sinus tachycardia. The heart rate is more than 100. So let's try to check. Okay, let's try to check. R wave that falls directly sa dark line, and you start counting. 300, 150, ano ba yan? Again, 300, 150, 100. Again, R wave that falls directly sa dark line, and you start counting. 300, 150, 100. This is 100, this is 150. So the heart rate of the patient is between 100 to 150 beats per minute. Therefore, it's tachycardia. And the RR interval, they are identical, they are the same. So with rhythm, waves are complete. P, Q, R, S, T. P, Q, R, S, T. One P wave in every QRS, one T wave in every QRS. In short, waves are complete. PR interval 1, 2, 3. 1, 2, 3. PR interval is normal. So sinus tachycardia. You have that in your notes. Remember, a sinus tachycardia is a tracing where the heart rate is more than 100. Waves are complete with rhythm. PR interval is normal. Okay, what medication do we give here? We give beta blocker, we give calcium channel blockers, and we do carotid massage. Next, sinus bradycardia. Okay, sinus bradycardia, I said a heart rate of less than 60 with rhythm, waves are complete. Okay, and PR interval is normal. So look at the waves. So we have here your P, Q, R, S, T. One P wave in every QRS and one T wave after QRS. And after T wave, you have your P wave. Okay, and look at the heart rate. Okay, let's start counting. Our wave that falls directly sa dark line is start counting 300, 150, 100, 75, 60, 50. So the heart rate is less than 50 or about 50 beats per minute. And the heart rate of less than 60 is considered bradycardia. And take note, R to R interval, they're identical. In short, pare-pare yung distance nila. In short, may rhythm. Okay, look at the PR interval. 1, 2, 3, 4, 5. So 3 to 5 small boxes ang PR interval. 1, 2, 3, 4, 5. The PR interval is normal. Okay, so this is your sinus bradycardia. Again, how would you describe sinus bradycardia? Sinus bradycardia is a heart rate of less than 60. Waves are complete with rhythm. PR interval is normal. What medication do we give here? We give atropine. Okay. Next is your atrial dysrhythmia. Remember, what did it tell you about atrial dysrhythmia? We give PQ and aspirin, procainamide, quinidine. Okay. And we also do cardioversion. In your atrial flutter, what did I tell you is for atrial flutter? My QRS complex. My QRS complex. No specific P wave because the P wave resembles sawtooth pattern. So para siyang ngipin ng lagare. See? Sawtooth pattern. Meron siyang QRS. So tandaan mo, ang atrial flutter po ay may rhythm. Pero pag walang rhythm, that is your fibrillation. So tandaan mo, ang fibrillation ay walang rhythm. Atrial fibrillation, ventricular fibrillation, walang rhythm. Hindi pare-pareho yung distance nila. So in atrial flutter, what do we do here? We give PQ, and apart from that, we do cardioversion. Paano ba mag-cardioversion? Eh kasi nga may QRS complex. Correct? 'Di ba sabi natin, we do cardioversion, we deliver the shock specific to our cardiac cycle, and that is usually in the R wave. Okay, or the QRS complex. This is your atrial did you see that? Did you get the difference? Look at your atrial fibrillation. Look at the distance of your R wave to R wave. R wave, R wave, R wave to R wave. Hindi pareho ang distance nila. In short, wala siyang rhythm. Samantala, in flutter, may rhythm sila. Pare-pareho yung distance. Normally, we use caliper to check the distance of R to R wave or R to R interval. Since I don't have caliper and we do this online, I think it's a hard time. I'm just doing my best to explain everything. Okay? And take note, in your atrial fibrillation, there's no P wave, no specific P wave. But guess what? There is QRS complex. Okay? So atrial fibrillation, this is your atrial flutter. So major difference, atrial flutter with rhythm, sawtooth appearance, atrial fibrillation with QRS, okay, no rhythm. Okay? I hope that's clear. VTAC, ventricular dysrhythmia. I said in your VTAC, ventricular dysrhythmia, the cadence tracing is wide and bizarre. We have it here. Wide and bizarre. And may rhythm. If you check, pare-pareho yung distance nila. Pare-pareho. In short, may rhythm sila. Okay? So VTAC is a deadly dysrhythmia. We do cardioversion during VTAC with pulse, and we do defibrillation during VTAC that is pulseless or unstable VTAC. Okay, common meds given here will be your lidocaine and magnesium. We give magnesium because we want to prevent torsade de poids. So this is your fibrillation. Look at your fibrillation. There is no rhythm. Remember I said fibrillation, walang rhythm. So in ventricular fibrillation, it's chaotic and disorganized. I also said that. Okay, I wrote that a while ago. Look at the difference. Tachycardia, VTAC, pare-paro yung distance. Fibrillation, disorganized, no rhythm at all. So the management approach here is your DILM. We do defibrillation. we give epinephrine, we give amiodarone, we give lidocaine, and we give magnesium sulfate. Okay? So acetone, this is your flat line. Okay, flat line. And I said we do not defibrillate acetone, we do CPR. We need to convert this acetone to ventricular dysrhythmia. So once converted, that's the time we identify if it is shockable or non-shockable ventricular dysrhythmia. Okay? That's your asystole or asystole. Now let's proceed to your AV block. Look at your AV block. Okay? So this is your P wave, P wave, QRS complex T wave. So waves are complete. May P, may QRS, may T. Isang P before QRS, isang T after QRS. Waves are complete. The main problem is that the PR interval is prolonged. How many boxes are this? 1, 2, 3, 4, 5, 6, 7, 8, 9. There are 9 boxes. Normally, it's 3 to 5. So lahat sila na PR interval niya prolonged. So that is your first degree AV block. Okay? Look at your second degree AV block Mobitz 1. I said in second degree AV block Mobitz 1, the PR interval gets progressively longer. Okay? There is progressive longer PR interval. And after that, there is a drop in the QRS and it goes back again to its normal tracing. And then you will have another cycle of your second degree AV block Mobitz 1. Okay, so this is your second degree AV block Mobitz 1. The PR interval gets progressively longer. Waves are complete. Okay, this is your second degree AV block Mobitz 2. Remember, I said in second degree AV block Mobitz 2, usually there is more than one P wave in every QRS. So this is your P, your Q, your R. This is your S, T. After T, P. There is another P. So there are 2 P's now in every QRS. But if you use the P wave near to your QRS, you will have a normal PR interval. Normal PR interval. But if the PR interval is inconsistent, okay, inconsistent, pwede normal, pwede prolonged, then that is your complete heart block or your third degree AV block. So tandaan lang, if the PR interval is consistently normal, okay, pero more than one P wave in every QRS, then that is your second degree AV block Mobitz 2. But if the PR interval is inconsistent, pwede normal, pwede prolonged, then that is your third degree AV block or your complete heart block. And this type of AV block will require pacemaker implantation. Okay? And this is what we call the PVC or premature ventricular complex or premature ventricular contraction. Remember, there is no P wave. Kasi ideally, bago mag-contract yung QRS, bago mag-contract ang ventricles, magko-contract muna ang atria. Remember? If you look at me, di ba sabi natin, P, QRS, T. P, QRS, T. Bago mag-contract ang ventricles, dapat mag-contract muna ang atria. But the problem with your PVC is that hindi nag-contract ang atria, automatic nag-contract yung ventricles ng patient. And after that, there is a compensatory pause. Okay? There is a compensatory pause. This is a compensatory pause. Let me do that. This is a compensatory pause. And I said 3 or more PVCs in a row or 6 or more PVCs in 1 minute, that is alarming. That could be an indication of a pending cardiac arrest. And I said 3 consecutive PVCs is called ventricular tachycardia. But again, may mga pasyente po tayo na normal sa kanila yung PVC because they have an existing cardiac problem. So don't be surprised. That is why it's so important for you to know the history of your patient. Okay? So I think that's all. I hope you learned something. Ang sabi natin, ang dami pa pong mga tracing that you have to understand. But these are common tracings, okay? And I hope you learned something, okay? I told you that the ECG tracing, electrocardiography is a lengthy topic. But I hope you learned something, guys, okay? Okay. So that's it. I hope you learned something. And thank you so much for your time. What, ilang oras ba tayo? And if you don't have any questions, let's call it a day and let's call it a night. Thank you so much, everybody. And please watch out because I might have another session of live streaming anytime soon. Okay? And maybe i-discuss natin yung ni-request sa akin dito. Where is that? Here. Was requested to talk about this. Ang dami nito. Oh God. But I will try most probably tomorrow. And by the way, for those of you who will join the qualifying examination tomorrow, if you will pass, we will sponsor your NCLEX review for free. Okay? So thank you so much, nurses. God bless everybody. Keep safe. My God, napagod ako dun ah. Usually sa actual review, I discuss ECG for whole day. That's 8 hours. And the cardiac discussion, dinidiscuss ko ilang 3 araw. Okay, thank you so much, everybody. God bless. And keep safe, okay? And I'll see you very soon. Bye, everyone.